Hello, everyone. So today I'm here to discuss with Dr. Gustavo Avila-Ortiz about our commissioned review for the 2024 AAP consensus paper, analyzing whether combining adjunct therapies such as lasers, air polishing devices, antimicrobials, probiotics, or photodynamic therapies with standard peri-implant debridement may provide meaningful clinical benefits for the treatment of peri-implant mucositis. To further explore these implications, I am really fortunate to be here with Dr. Avila-Ortiz, who will share his insights on how they may influence clinical decision-making in daily practice. So thank you, Gustavo. Could you share with us how you define standard debridement in your daily clinical practice?
Absolutely. Hello, Alex. Hello, everyone. It's a pleasure to be here. So to address your question, in my clinical practice, standard debridement or debridement, which would be the preferable term, refers to thorough physical removal of biofilm and calculus around the implant using either manual instruments or power instrumentation specifically designed for implant surfaces, as well as air polishing devices. To me, the main goal is to disrupt the microbial biofilm and eliminate calculus deposits without damaging the implant surface or minimizing the release of microparticles of the titanium or the titanium alloy of the implant body. And I also believe that it's equally important to provide our patients with adequate education and to reinforce oral hygiene instructions, because optimal biofilm control is performed ideally both by the professionals but also at home. And this is the foundation and the key for the management of most oral inflammatory diseases, including peri-implant mucositis.
Yeah, thank you, Gustavo. I think that's a very, very thorough insight, and thank you for defining the standard debridement or debridement for all of us. So let's think about the more clinical practice standpoint. Do you typically use adjunct therapies when you treat peri-implant mucositis?
Yes, I do. But I do it in a selective manner. I believe that adjuncts such as antimicrobial mouth rinses or probiotics may be helpful, may be of use, but they should be considered depending on the clinical situation. The paper that we co-authored together reinforces that adjunctive therapies should not replace a standard debridement and self-performed microbial control. This has to be very clear for all of us. And having said that, in many cases, conventional therapy alone is sufficient to reduce inflammation, provided no other uncontrolled local and systemic contributing factors are present.
Okay, that's great. So how about the main clinical outcomes that define the treatment success for peri-implant mucositis? As we all know that, yeah, in this kind of disease has been very, very prevalent nowadays. And people have been proposing different treatment modalities for peri-implant mucositis. How do we really consider the true treatment success for, treating peri-implant mucositis?
Yeah, so we know that peri-implant mucositis is an inflammatory condition that is mainly confined to the peri-implant mucosa, right? So the key parameters to me are visual signs of mucosal inflammation, such as erythema and edema, as well as bleeding on probing and probing depth. The key to me is reduction in bleeding on probing. This is particularly important because it normally reflects improvement in peri-implant tissue health after the treatment that we have delivered. And I also evaluate microbial biofilm control and patient compliance in subsequent visits after the initial professional care. Because as we all know, long-term health depends on patients' ability to maintain good oral hygiene and compliance to the maintenance program that we recommend.
Thank you. Yeah, so going back to the review, I mean, this article that we co-authored, this study actually didn't really find adjunct therapies provided, clinically significant benefits compared to just standard conventional peri-implant debridement alone. So what is your perspective of these findings, on these findings?
Yeah, I believe that most of us who treat patients in a regular basis observe these findings. It is aligned. So I also think that professional treatment based on conventional debridement combined with optimal microbial biofilm control on the side of the patient often leads to meaningful improvement. However, adjunctive therapies may provide benefits in certain situations. But based on the results of this review, they do not dramatically change the outcomes. This again highlights the importance of focusing on the fundamentals of treatment, which are patient education, optimal biofilm control, control the etiologic and contributing factors, and a personalized maintenance therapy program.
All right, that's great. So this study also showed that the smokers and the vapors experience really minimal benefit from adjunct therapies, or even just from the peri-implanted debridement itself. How does smoking really influence your treatment approach?
We know from classic literature in the field of periodontics and also more recent evidence in implant dentistry that smoking negatively affects tissue healing and alters the immune response. And that can definitely compromise the outcomes after therapy. It's not only involved in the onset of disease, but also the response from the patient or those sites that we treat. So for smokers and vapors, I emphasize risk factor modification, in other words, behavioral changes to achieve cessation, along with more strict than other patients that are at lower risk maintenance programs. In general, not only for smoking, but without addressing the most relevant risk factors, even if we perfectly execute our professional therapy, the effectiveness of this treatment may be compromised.
Yeah, I mean, I totally agree with you. It's really about personalized treatment planning and the risk assessment, depending on individual patients' risks. So next topic would be more interesting about the complete disease resolution. I think this is a very, very popular topic nowadays because how predictable that we are able to achieve complete disease resolution for peri-implant mucositis treatment, meaning that we are gonna get a shallow probing depths and the absence of the bleeding on probing while we finish our treatment for peri-implant mucositis.
Right. This is an elusive term, as you very well know. What does it mean, right? So I think complete resolution can occur, but from what we know out of the most current evidence, is not a predictable outcome. Many studies report a resolution rate between 30 and 40% after treatment of peri-implant mucositis. And achieving total resolution depends on multiple factors, such as patient compliance, implant position, prosthetic design, and other local and systemic factors. This has been clearly illustrated in the findings of a recently published systematic review by Carlos Garaycoa and collaborators that was released in IJPRD less than a year ago. So I encourage everybody to check that out. And I would finalize by saying that our goal should be to improve tissue health and arrest the progression of peri-implant tissue breakdown, rather than expecting perfect outcomes every time that we are dealing with peri-implant diseases.
Yeah, thank you. I read that paper. It's a really great work by you and Dr. Gary Koa. So I also encourage everyone to read that paper. Really further define the complete disease resolution, and as we all know, it's not really realistically achievable for all the cases. So it's a very interesting topic that people still need to investigate in the future. So from our work, AAP consensus paper, what are the key clinical takeaways that you would suggest for the clinicians, just to like a take-home message?
Yeah, so as a matter of summary, I would say that conventional debridement and optimal self-performed oral hygiene for microbial biofilm control, along with addressing concomitant contributing local and systemic factors, remain the cornerstone for treating peri-implant mucositis. I think that adjunctive therapies may provide an additional benefit in certain cases, such as in high-risk patients with limited dexterity, so they don't have optimal plaque control and some other conditions, but they should not be considered a replacement for standard therapy and patient education.
Yeah, thank you. As we all know, every single study has its own limitations. So what are the main limitations of the current evidence, and what research is still needed on this topic?
Well, I would say that standardization at different levels is important because many studies use different definitions to address or to determine what is peri-implant mucositis in the context of that study, and the same applies to different treatment protocols. So for us to be able to extract clinically relevant conclusions from such a heterogeneous body of evidence is challenging. So I think that future research should focus on standardizing these diagnostic criteria and outcome measures, as well as testing head-to-head consistent protocols that can be reproduced in practice. It would also be of great value to study factors such as implant surface characteristics, prosthetic design. This is a big one to me because many problems that we see related to peri-implant diseases have a relationship with far from ideal prosthetic design, and as well as maintenance protocols and how they can influence the outcomes and the stability of our treatment over time.
Yeah, thank you. I agree totally. Because as we all know, peri-implant diseases are multifactorial. So it is not just plaque. It could have so many different components contributing to the disease occurrence and reoccurrence. So like you said, a lot of factors, restorative-wise or compliance-wise, everything plays a role into the development of the disease. So yes, we need to look into this further, and hopefully the future studies would help us to really improve our treatment approach and also advance the patient's health. Lastly, let's talk about the summary of this paper. So what should these findings influence our daily practice for clinicians?
Yeah, so if we understand the limitations that we have treating these diseases and the limited body of evidence that we have available today, I think that a logical consequence would be to focus on prevention. Let's try to avoid from these diseases to be as prevalent as they are today, right? And how do we achieve that? So again, the foundational concepts of patient education, monitoring, early diagnosis to treat the disease when it's more manageable, effective debridement, and personalized maintenance are, to me, the keys. And again, adjunctive therapies can be considered selectively, but the real key is solid idiotropic therapy, including risk factor management to arrest the onset and the progression of peri-implant diseases, including peri-implant mucositis, which is our focus today, but also peri-implantitis.
Thank you. Yeah, I know that, like you said, prevention is actually the key, and there is much more effort. I know that you and Dr. Purnima Kumar are leading an effort for the next best evidence consensus meeting for our AAP to really discuss the primary prevention, primordial prevention for peri-implant diseases. So I think that will be very interesting. I look forward to hearing more about disease prevention from that great evidence consensus meeting. So
Thank you, Alex.
yeah, thank you. We are very fortunate to have Dr. Gustavo Avila today with us sharing his thoughts. And hopefully that we can hear more feedback from you, the clinicians, letting us know what you think about the paper. Thank you, everyone.
Thank you.